Hello, everybody, and welcome to today's webinar. My name is Sabrina McCarley. I'm with Transitional Care Management, and I will be the moderator for today's webinar. We are so excited for today's webinar, and that is an introduction to the OASIS E and your role in home health value-based programming. We have some incredible panelists with us today: Cindy Kraft with K&K Healthcare Solutions, Shannon Leem with Aegis Therapies, and Sherry Teague with K&K Healthcare Solutions. Before I turn it over to our panelists, I would like to go over a couple of housekeeping reminders. All attendees are on mute for our webinar. The handouts are located on our NARA website, and there is a link on the slide there to give you to the resources and the quick links. They will also be included in the follow-up email. If you have any questions for our speakers today, we ask that you type those into the Q&A. Sherry's going to be helping in the monitoring of those. If you do have any technical questions or experience any technical issues during today's webinar, we ask that you type those into the chat button, and Christy is monitoring those. For the recording, because today's webinar is being recorded, it will be available for all NARA members via our portal by August 8th. It will also be posted for all other registrants on August 9th on our NARA website, and the link to that is also listed here. We wanted to cover a disclaimer for today's webinar. The information that we are covering today in our presentation is shared truly in good faith and for general information purposes only. It is accurate as of the date and time of this presentation. All providers should seek further guidance and assistance from CMS, as well as their Medicare Administrative Contractor, their MAC, commercial payers, state and national associations, and also continue to watch for new developments and information regarding the topics that we're going to be discussing today. We are going to be covering a lot today, as you can see. I'm going to allow each of the panelists to really introduce themselves when they do their presentation, but we will be covering an introduction to the OASIS E, as well as value-based purchasing, the role of therapy within OASIS E, and then at the end, we will be covering our attendee question and answer. So with that, Cindy, I am going to turn it over to you.
Well, I'll kick off our intros. My name is Cindy Kraft. I'm one of the owners at K&K Healthcare Solutions. I'm a physical therapist by background. I've been in the home health space now 28 years. Have a passion for OASIS, which might lead to someday getting some sort of ICD-10 code associated with that dysfunction. But I'm very excited to be here to talk about both OASIS E and value-based purchasing. Shannon?
I'm Shannon Leem. I'm the National Clinical Director for the home health side of Aegis Therapies. I live in Florida, and like my initials say, I'm a speech therapist in the home health realm, which makes me sort of a unicorn out there. So I've been on the home health side of things since about 2012 for Aegis Therapies. I did home health back in the 90s when it was a completely different animal back then, but look forward to hearing some of your questions today.
And Sherry is also an owner at K&K, and she's having some weather issues where she is. So she is going to be monitoring the Q&A box. And I want to reiterate, we welcome questions coming in that way. You don't have to wait for the end or a specific time. If you have a thought that strikes you or a comment you'd like to make while we're speaking, please go ahead and fire away into that Q&A box. So I'm going to start with OASIS E. And yes, it is effective January 1, 2023. I often wish that somehow home health had gotten a similar deal to skilled nursing facilities whose things start in October, because everything that hits us in this setting hits January 1, which means the prime real estate for preparation and refinement is always during the run through the major holiday seasons. And under normal circumstances, that is one of the worst times in home care because so many people want to be home, so many staff want to be off, there's so many competing priorities. I often say you can tell how long you've been in home health by whether or not you twitch at the first holiday commercial that comes on and go, oh gosh, can it really be that time of year again? Because things can get really dicey. So what we want to focus on is how do we prepare for this and understand what to prepare for in the most calm way possible, not in a Pollyanna, let's pretend it's not happening, but in a realistic approach to making sure we're ready for this. And that has a lot to do with putting it in its proper context. Anytime there's a major change in OASIS and they change a letter, that tends to cause a degree of panic. It's not a minor adjustment now. We're doing big things. Many remember when it was all the way back and we started this thing with OASIS B earlier in the alphabet. But what's interesting to note is that 75% of OASIS E is in fact OASIS D. I want us to make that sort of a mantra as we approach the effective date, because not everything is new, not everything is chaos, but it does remind us that we have to currently have our house in order. If we collect OASIS data now and we're rocking and rolling and we hardly ever get corrections and we know what we're doing and we know what the guidance is, then we can be calmed in knowing that we are 75% of the way there, and maybe we didn't know it before we thought about it today. What that tells us then is that we have 25% that we do need to focus on. And when we focus is going to hit in that highly competitive holiday arena, because if we prepare too soon and can't actually use it, the likelihood is we're not going to be able to remember it. So our goal here is to touch on some of these new items. And we may look at this and say, what the heck is going on? I've been very used to OASIS is M items. I mean, we called them M items, or some folks said moo items, which I never understood. There weren't two zeros or two O's, but anyhow, what we're going to see in OASIS E is a reorganization. They're really moving it toward these sections, different sections. And these are not all of the sections in this slide and the subsequent slide. These are just the sections that are being impacted by new items. So there clearly is a reorganization of content. And I think that that's not a terrible thing. I think many of us who spent time with OASIS for a while have tried to make our own kind of groupings as far as following it more like a system by system assessment. It's kind of nice to see they're trying to structure it that way as well. When we look at section A and go, oh gosh, that took a whole bunch of new ones. Well, let's again put it in perspective. A 2120 through 2124 are basically variations on a very common theme, which is going to be an updated process measure related to, are we providing a currently reconciled medication list to the next level of care if the patient is going to the hospital or a skilled nursing facility, or to the patient themselves if they're being discharged. What's interesting also in section A is we see questions related to ethnicity, race, language, and transportation. What we see in those items is an interesting development that the patient, if they are unable to respond to several of these, we have the option of looking through medical records or talking to a proxy. So their family member, their caregiver can answer on their behalf. If that is what happens, our directions as far as choosing a response is we choose the patient unable to respond option and the answer that was given to us by the proxy or the medical records. To me, that's a great example of, I would just think patient unable to respond is unable to respond. Oh, it gets better. The patient can also decline to respond. And if the patient declines to respond, then that is the only answer I can pick. It doesn't matter if I have the answer clear as day in the medical record, or the daughter is telling me exactly what the correct answer is. I can't use it. I have to stick with patient declines to respond. I say that here because those are some examples of the nuances of OASIS guidance. We have to remember OASIS is discipline neutral data collection. It's not a therapy assessment. There are no nursing questions. It really is capturing bits and pieces of information. And it's like participating in a 20+ year research project. We didn't necessarily volunteer for it, but we've been conscripted into service for it. If we're going to collect data, we have to make sure we're following the guidance. It doesn't always follow our clinical logic, and we need to stop making that a negative or a source of frustration and just say the directions are what they are. I just need to follow them, which definitely influences a lot of the rest of these items, particularly when we get into cognitive patterns, into mood, into issues around pain. In OASIS E, the manual is very clear that the expectation is we are going to read the question to them verbatim, and we choose the response based on what they tell us. There are very few questions in those sections that are interpretive. So this is going to raise some issues for clinicians that have still desperately held on to the idea that taking their device into the home is somehow an obstacle or a problem or a barrier, and continue with the I'll just make notes to self and then fill in this document later. That is not going to work with OASIS E. There are multiple items where I'm going to have to read it exactly, and I sincerely hope an electronic medical record, we don't do this to ourselves and carry around a printed out copy and keep writing notes that cause double documentation. But I think that having questions we have to read as is not that difficult. I mean, we don't have to come up with some sort of assessment strategy. We read it, we take the answers, and our EMRs are going to be able to assist us with respect to calculating those responses. But if 75% of it is old, maybe some of it has not really gone as smoothly as we think it could. And as therapists, I think we have an opportunity here to look at several of these areas. What we see here at K&K, and we do a significant number of outsourced coding and OASIS reviews, is there are continual patterns around where errors occur and cause there to be a need for corrections. Cognitive behavioral things, underreporting of concerns, seeing that the word forgetful is used in documentation, yet item 1700 is scored as response 0, that the patient is alert and oriented, able to focus and shift attention and recall task directions independently. Well, that doesn't really fit with forgetful. Wounds, are we following those directions and clearly assessing as we need to? And yes, there are things that CMS has decided count as a surgical wound and things that they say don't. Anything that ends in an ostomy does not. If we keep trying to answer somebody with an ostomy is surgical wound, yes, you're going to keep getting that back for corrections. Medications, not just the issue of are there issues and reminding ourselves of what those issues could be, but also in relation to medication management. As therapists, that item 2020 and 2030 for injectable medication is about knowing what to take and when, but also where is it kept? And how do functional or cognitive impairments affect a person's ability to manage their medications? Because if they miss a dose because they forgot, if they miss a dose because of where it's kept, we can play a direct role in addressing that issue for our patients. And yet I've never really seen a physical therapy evaluation in the gait assessment include where is the location of the medications? Where are they routinely kept? I don't see OT evaluations actually demonstrating opening of a pill bottle. I don't see speech evaluations necessarily connecting deficits identified to how does this affect your medication management. So we have clear responsibilities there with respect not only to OASIS data collection, but also care planning. But the one I want to touch on for a moment seems to be the biggest offender for the corrections process, and it is the functional assessment. And I think as therapists, we've kind of been informed that we are somehow naturally better at this, but that's not really what I see as I audit records. I think on the assistant side, the OASIS definition that basically puts everything together. So if I provide verbal cues or I do hands-on, that all counts as human assistance. If you've been in home health long enough, you probably resigned yourself to this. You don't like it. As therapists, we have all kinds of differentiations of assistance. But OASIS is not a therapy assessment. It lumps it all together. Where things can get frustrating, regardless of discipline, is this idea of safety, especially in individuals that live alone or have inadequate caregiver support or caregiver support that's trying but is probably making things worse. We know we have to look at a holistic approach here, not just their physical and cognitive abilities, but what does that environment look like? If the environment is contributing to a safety concern, then that needs to be taken into consideration as we choose a response. Medical restrictions, you're not supposed to climb upstairs, says the doctor. Only bathroom is upstairs. Absolutely has to be part of this choosing a response decision. Do they have pain? Do they have fear? Are there's equipment? Well, I see too many times, well, there's equipment in the house. Therefore, you know, we know full well that you can have a piece of equipment in the house and use it wrong, and it actually make things worse. So we understand that holistic approach, but I challenge us to think about the connection between function and fall risk. Now, I want to be very clear here. This particular item, 1910, is not coming over to OASIS E. It's going away. Now, I've already had people say, oh, we don't have to assess for falls anymore. Oh my gosh, that is not what this says. This is a process measure that for years has been trying to figure out if agencies are using standardized and validated fall risk assessment tools. That's why we have yes, no responses. Well, the data indicates overwhelmingly yes. which means, all right, if we're all doing it, why are they going to ask us the question anymore? That's fine. So don't, but we are going to continue to assess risk for falls. And if we have determined that an individual is at risk for falls, do we think they should be at least supervised while they do things? This is something we can also reach across the aisle to other disciplines and help them understand this issue from the perspective of at least supervision due to an identified fall risk needs to be taken into consideration because it's measured as assistance just as much as if I had to boost somebody during an activity. We also have to keep in mind about the words do matter. This is a very commonly missed question by many disciplines off of the word or. So response 1 is able to transfer with minimal human assistance or an assistive device. So if that person is using a cane and you think they should be supervised due to fall risk, they are response 2, not response 1. If it's a walker and some supervision or walker and some verbal cues, that is not response 1. That is response 2. And I know we don't like the wording. And if we had 3 more hours to debate it, we could open up the Q&As and have a lot of fun with this. But the reality is this has been a long-standing definition and it's going over exactly into E. They are not changing the wording on this. They are not changing the guidance on this. So we need to make sure we are on top of that 75% now. Because if we can master that today, we can confirm that our teams and our staff are good at this today, then we've already taken care of the vast majority of issues as we prepare for E. And then as E gets closer, then we need to delve deeper into those new items using the guidance. The guidance manual has been overhauled in ways I hadn't even expected by creating more robust resources related to tips and examples for questions that can really help us understand it from the source document. Now, you can't really talk about OASIS E or OASIS in general without the collision now between OASIS E implementation and the expansion of value-based purchasing. Now, some of you may already practice in value-based purchasing states and say, yep, I already know this, but a lot of you do not. And you already are technically, because the issue of effective date is when they're going to start collecting the data as a comparison measure. The proposed rule for 2023 has adjusted the baseline year, but the bottom line is they're going to be measuring a quality shift between the baseline year and what we do in 2023. What I think is important to remember, and the next 2 slides come from a recent report on the demonstration project for value-based purchasing, that the big driver for expansion was money savings, not dramatic quality improvements in the demonstration state. What they really looked at was the amount of money that they were able to save by reducing rehospitalization and reducing use of skilled nursing facility. I want us to keep that in mind as we talk in the next few minutes. Their big takeaway was expansion should happen because of the monetary savings that home health can provide by keeping people out of higher cost care. Were there some quality gains in those demonstration states? Yes, but they referred to them, in their words, not mine, modest gains. So I'm not saying that we're going to ignore the quality measures going into value-based purchasing, but I think we need to balance it, particularly on the therapy side, against the bigger ticket item of, are we keeping them out of higher cost care? When we look at what's included in the value-based purchasing measure, we see that 35% of it is coming directly from OASIS. And this is a primary reason why 75% of it is not changing with E, because anything related to payment, anything related to STARS ratings, anything related to value-based purchasing is untouched. So it's already embedded in too many things for them to change the wording or change the guidance substantively. So a lot of what we're dealing with today is going to carry over in terms of, you can see the items they've selected: dyspnea, discharge to community, oral meds, which we touched on a minute ago. When it comes to function, though, unlike STARS that kind of, one-to-one, ambulation, bathing, and transfers, this is getting into total normalized composite. Being a participant in the technical expert panel building toward value-based purchasing, the issue was, is it really fair to say, in order for there to be improvement in function, you're going to improve every single thing individually? Or really, should it be more of a net gain? And that's essentially what these total normative composites are: a net gain related to change in mobility as well as change in self-care. We see that another third of this is coming from claims-based. Not a surprise, acute care hospitalization and ED use. And then a remaining third is coming from the patient satisfaction survey. So we're going to have to make sure our efforts to participate well in this program are that we are active participants in our organizational efforts to manage the patient satisfaction survey issue. But we can see which items are included. And these are very familiar pieces of information. And as therapists, we have often been pigeonholed right into this. And to my co-presenters, being a speech pathologist, it's been a long-standing, well, none of these are for speech. PT gets these and OT gets, okay, first of all, there are no therapy outcomes. Can we please stop? Okay, because the only way there could be therapy outcomes is if therapists saw every single home health patient under the Medicare program. Then we could be exclusively accountable for what happens with these, but they don't. There's a lot of patients that come through home health and don't ever see one of us. So we cannot continue to be seen as solely responsible for this. And when we are involved with the care, what are we actually trying to accomplish? Because when we look at this issue, when we think about outcomes, we can very quickly make it an OASIS issue, that we need to make sure the OASIS is measuring correctly. And that is absolutely true. Okay, I like to use a completely different example that is not an OASIS example. Let's say I want to change my weight. Okay, and if I want to do that, I need to have a workable scale. I need to have a scale that is reliable, consistent. I can't have one that's janky. I can't have one that doesn't work right. It's going to mess my whole plan up if I cannot count on that scale. But if I weigh myself on that scale and I weigh myself 2 weeks later and I don't like what I'm seeing, that's not the scale's fault. That's far too often what I see in the discussion of outcomes is this, especially in the classic scenario of nursing did the admit, therapy did the discharge, and as therapists, we say, oh, that baseline score was wrong. Okay, that could be part of it, but part of it may also be what has been our intentional actions between these 2 points to achieve the desired outcome. And that desired outcome may be improvement for some of our patients. In others, it may be stabilization with a maintenance approach to care to prevent decline. So where am I going with this? Well, the ambulation question, love it or hate it, is going straight into OASIS E. And breaking down our response options in real terms, 0 or 1 indicate this patient is a fully safe and able ambulator on all surfaces they need to encounter, inside and outside of their home, to get to the car, to get to the doctor. Surfaces in their environment, 0 or 1 are completely safe and able. The only difference is a 1 happens to have a piece of equipment. Okay, moving down to 2 and 3. The difference there is intermittent versus continuous need of another person. So if I believe based on risk for falls, this patient needs to be at least supervised, then I now have to determine, is it intermittently or continuously? Do I want someone with them, keeping an eye on them every time they're up and about? That's a 3. Do I think they're okay on some surfaces in that I would leave them completely alone and only provide supervision or assistance in certain circumstances? That's a 2. And I know you're going, you know what? That's not what it says. 1 says one-handed, 2 says two-handed. The guidance language is at the bottom. It is unchanged in E. This is not about equipment, no matter how they poorly worded it, and they did not fix it. Okay, so what does this mean for us as therapists? Well, if I'm working toward this, is my traditional physical therapy gait training focused on distance, device, and level of assistance going to get that desired outcome? Or do I really have to think about, why is this individual having this problem? We know that we've seen denials of therapy services when we keep just going minimal assist for that and moderate assist for that, and don't use our skills to say, what is the underlying reason? Weakness, balance, environment, cognition, any and all things in combination. But do we ever look at how we provide assistance in terms of intermittent versus continuous? Because what I hear a lot of at discharge is, well, they're still going to need supervision. Yeah, okay, but all the time? Or have they reached a point where they're safe and able inside their home, but if they were going to go down the stairs, you would want them supervised? Well, yeah, then that's intermittent assistance. That's a big difference between discharging somebody as a 3 or a 2. Or do they have a piece of equipment and they're good in all of the surfaces that they need to address, but it happens to be a walker? So what? They would be a 1. they have a piece of equipment, and they've been deemed safe and able. So I'm challenging us to really use what is the underlying problem, because sometimes the problems related to gait are not all physical therapy to solve. If we've got major cognitive issues going into it, then working collaboratively with speech to address this can really be huge. And are we really thinking as the provider about the inclusion of continuous versus intermittent in how we think about goals, how we think about intervention, how we think about assessing? Picking one other one is bathing. Don't want to leave our OT friends out. This question follows the exact same track, okay? To be a 0 or a 1, you're a completely safe and able bather. I would say take that shower when no one is here, okay? Only difference is that number 1 has an equipment. 2 and 3, same deal. The big difference here is intermittent assistance is a 2, continuous assistance while you're bathing is a 3. And clearly, if we have a person who's just come home from the hospital, just come home from the nursing home, we haven't really met them before in a community referral, they have failed our fall risk assessment, baselining them as saying, if you were my grandma, I would want to supervise you at least while you do this today. I'm not saying it's forever, and neither is the item. It's asking about the day of the assessment. Now, in the 24 hours preceding, I would feel better if, then the true baseline is 3. But again, are we digging into the underlying reason for this patient that they are requiring assistance to bathe? Are we integrating the continuous versus intermittent element? Because I think when we don't, we're creating roadblocks in the conversation about, well, this patient isn't going to get any better. Well, okay, I know we're wired to say better means everybody should be independent by the time we're done. That would be our ideal. That's what we want everybody to be. But we're realistic in this space, and not everybody's going to be. So, oh yeah, they might still need supervision when they're done. But again, is it continuous or intermittent? That makes a huge difference with respect to choosing the correct response. And it's not just about knowing that when I'm the one who has to answer the question, it's knowing that when I am planning care. So what does this give us here? We have an opportunity, and I have a slight technical delay. I don't know why it's spinning around and not going to the next slide. I've learned not to touch it because then it will jump all over the place. I will just leave that there. But what I'm trying to get to here is, yes, we have our opportunity to be able to directly impact some of these tried and true outcomes by enhancing our focus on the underlying reason and intermittent versus continuous. The other thing is we cannot forget that the big ticket reason they expanded it was the reduction in the utilization of skilled nursing facilities and hospitals. And I think far too often, all 3 therapies have been lumped into, you guys deal with ambulation, bathing, and transfers, or in value-based purchasing, all these other functional things, and don't really take into consideration that what we do can directly impact keeping individuals at home that may not have improved significantly, may have stabilized as our goal, but the bigger issue is I kept them out of the hospital, I kept them out of higher cost care, and that is a good piece of what my value is. So Shannon, this is where you take over, but I still have a little weird little spinning circle to go to the next slide, and I'm not quite sure from a technical standpoint what I should do about that.
Well,
Cindy, I can bring up the PowerPoint on my
Okay.
end, share my screen.
That would be great, because this is a good time to do that.
Okay.
I'll just go ahead and stop my share.
Yes.
Nope, it did it. See, I told you, it gets weird and then it's, see, it sensed the movement. It's all yours, Shannon.
Outstanding. Okay, so what we're going to talk about here, Cindy's already laid out the foundation for therapy involvement, the role of clinicians, therapy clinicians in data collection, but I'm going to throw a dart and hit a few of the more finer points with some of this already. So the first slide that we're going to talk about is the role in the OASIS E. Cindy laid out the concept of therapy is definitely going to be involved. This is our wheelhouse. We are the functional experts, or we are looked upon as the functional experts in many ways. So the first couple of elements that we put here, what does the OASIS impact, right? She talked about the OASIS, it's changed through the years. She mentioned Care Compare. PDGM certainly has elements of OASIS impact in there from the functional impairment grouping that we're going to talk about. Home health value-based purchasing, we've already talked about, but we're going to spell that out in a couple slides. agency-specific quality programs use some of the OASIS elements, and therapy is certainly going to want to be involved in some of those elements for discussion. But below that, so we're going to get into those specifically, but 3 more bullets under here. So we've got training to accurately and thoroughly score. Cindy hit 2 of the big ones, transferring and ambulation. Because of that scoring mechanism there, therapists need to thoroughly understand the guidance. Therapists should not be punched on the arm and said, you've got a DC OASIS, good luck with that. You know, that should not be their first introduction, is when it's put on their schedule. Therapists need to be trained. Therapists need to understand the guidance. They need to understand the if this, then that scoring criteria. Not every question is convoluted and has all of these different criteria and guidance with it. Some of it's very straightforward. Others have some nuance to it. And the therapists do need to understand that. So whether it's having them read the manual and go through some element there, certainly mentoring a clinician going through it, do some ride-alongs, watch an OASIS be scored, side-by-side scoring, a seasoned clinician doing an OASIS and the therapist doing also scoring an OASIS side-by-side, and then doing a comparison. Did you get what I got? It's absolutely valuable, but however that is done, there should be a training element there, and we should allow for that to be done so that therapists feel confident in being able to not only perform the OASIS, but if they're not performing it, that they can still collaborate with the clinician who is performing the OASIS or holding that OASIS assessment. The second to last bullet there, the timely performance, that is by and large a really important concept in our review choice demonstration states. If you're out there, hats off to you going through that. Certainly with the notice of admission, there's a lot of time constraints now with home health agencies having to have this time time comparison be placed and have a stance that the agency and the therapist understand, hey, I have a deadline here. I can't just be holding back my information. I can't have my notes be draft. I can't wait to provide this information to when I think about getting around to it. There needs to be a structure to how that happens and an expectation to it as well. So that don't expect any of that timing or push for timely performance to go away. And then the last element there, collaboration or communication. I touched on it a second ago. Even if your therapists are not performing the OASIS, or whether it's the start of care, research, ROCs, DCs, if they don't touch an OASIS, that does not abdicate their need to understand many elements of the OASIS. We would not want them to say, hey, I'm not doing the OASIS. I don't know what you need. Here's my eval, read it, right? That's not the way we want to collaborate on the OASIS. The therapists need to understand the scoring criteria to some of these more important elements that we're going to talk about on another slide. So when you see the next elements that we're going to talk about, which are the OASIS impacts in those different categories, care compare. Look at the OASIS items that are important on care compare that therapists have an absolute role in making sure that scoring accuracy is there. Mobility. Care compare is phrased for the community to understand it. So it doesn't have that medical terminology. So you see walking instead of ambulation. So in these particular cases, you'll see mobility for walking, transfers, and bathing. Breathing, how does their breathing improve when they're with this agency, right? This is the public making an assessment about the agency related to the OASIS scoring for particular patients. Fall risk, medication management. Does the patient get better taking their medications by mouth? A great question. How does the agency score on that? Cindy touched upon that earlier, how there is an absolute role for all clinicians related to med management, and we'll talk about that in a minute. Prevention of hospitalization, big one. Value-based purchasing, we've already heard, ringing the bell, raising the flag. Big reason why we want to have value-based purchasing go nationwide is the result of the reduced hospitalization, reduction in the high-cost healthcare spending that is seen out there. So what role do your therapists play in preventing a patient's either hospitalization or a rehospitalization? We'll talk about that in another slide. Then I'm not going to belabor the PDGM functional groupings, but those are the OASIS elements that are involved in the PDGM functional impairment grouping level, high, medium, and low. So you see those there. And then the value-based purchasing outcomes, the total normalized composite scores for mobility and self-care, literally run through those M1800 items that we're very, very familiar with. Toilet transfers, ambulation, dressing, grooming, feeding. Therapy speaks loudly through all of these elements. So you can see here, by having a therapist who is well-versed, educated, and familiar with and comfortable performing either OASIS at any time point or collaborating to the start of care clinician or to the OASIS clinician about just these elements. Let's forget all the others. If we're going to be overwhelmed by OASIS, be overwhelmed by the other pieces, not these. These speak to our license. So to that element, having a therapist understand the scoring criteria and the response measures for all of these individual items, you will have a therapist that is worth their weight in gold to a home health agency. Okay, so let's take a look at more specifics. So in the home health value-based purchasing, we talked about the OASIS measures, we talked about all those particular elements. So what is the role in the clinician specifically to value-based purchasing, right? We've got our first performance year that's coming up, 2023. So that's the first year where we are going to be compared to that baseline. So our first, how did you do? So in Cindy's scale comparison, it's the 2 weeks of the diet. How did it go? Get back on the scale. So 2023 is our year-long scale. Getting on that scale, did the diet work? Okay, so having our therapist recognize what is my role in helping this agency perform better as compared to their, in this case, 2019 levels. So accuracy, thoroughness, that's paramount for all of these elements. But specifically, if we throw a dart at the one element, and Cindy had it on a previous slide, one of the elements of value-based purchasing for comparison is the patient's improvement in dyspnea. If the patient had a deficit with dyspnea, how did they get better? Do we see a marked improvement for patients who have dyspnea? For our therapists, do we have them documenting breathing interventions, using dyspnea scales? Do we have functional and measured endurance training functionally for this particular patient? Not just the patient gets up and is able to walk to such and such destination with min assist. That's not functional endurance. That's not necessarily going to support a change in dyspnea. But if we have a measure, a respiratory rate, an oxygen level, a perceived level of shortness of breath for the patient prior to an activity, and we have them do this functional activity, walking, whatever ADL activity, what have you, and then remeasure that. What's their respiratory rate? What's their perceived level of exertion they did here? Do we have any O2 stat change noted here? How much time does it take for them to rebound to a normalized level of vital signs? That is functional and measured endurance. And I see, by and large, when I do documentation audits, and I think at this point in my career, I can probably say I've done thousands of audits at this point. Maybe let's go with millions. I'm feeling like it's millions of audits that I've done. And to that end, it is the rare bird sometimes that I see documenting true functional changes, functional endurance. They'll say progress or goal for next week is to work on functional endurance. And then I don't see anything that says physically and physiologically what they're going to do to change endurance. So that endurance element, really important. The acute care hospitalization or the emergency department use. We absolutely can be a gatekeeper to keeping this patient out of an emergent change in their condition. Focusing on durability of response. I've got a slide that we're going to go into. What is durability of response? In a nutshell, it's can they keep doing what they're doing when they're with us when I'm not around, right? It's the sticky stuff I give them as a therapist. So we're going to go into that in a minute. And that means, so when they're better with me, they're also better without me. So that helps to reduce a hospitalization event, potentially, right? That's our hope. Focusing on vital sign analysis during the intervention. I think all of our therapists recognize going in, taking their vital signs, usually at the start of care, right when they get in the door, they do their quick med management question, they go through their vital signs. One would hope then that they're tying those vital signs into their treatment interventions. Pulse, respirations, blood pressure for those patients who suffer from respiratory impairments, that have cardiac impairments. You want to make sure that the patient's physiological response to this activity, one is okay, right? We don't want to create a catastrophic event with the patient medically. And two, it's going to give you insight into how the patient is able to improve, right? We haven't touched upon homebound here. Homebound is not an element in the value-based purchasing. It's not a concept that we're talking about from a measurement standpoint, but we kind of need to remember we're targeting all of our treatments to getting the patient no longer homebound. So whatever it is that's creating that homebound criteria, whatever that characteristic is, and many times it is shortness of breath, it's fall risk, it's the patient's cognitive ability to navigate a new and unusual situation. Are we addressing that? Are we throwing a dart and hitting it in our documentation and in our treatment interventions? Condition management. Sometimes we as therapists, and I think if you've been a therapist for longer than a minute, you've had a patient like this, where they'll say to us, you're the first person who's explained to me what's happening and why it's happening. And I think that's, we should hold that with pride. We should also make sure that we recognize that it's important that a patient and the caregiver by extension understands what are all these diagnoses, what are all these impairments we're seeing, and what it is that I'm doing with you, how that's going to help resolve it. And then when I'm not here, how does the patient recognize those elements in themselves? How does the caregiver recognize what's happening so they can modify and make changes to prevent a catastrophic change in their medical condition, to prevent a hospitalization? Recognizing that when I do this at this particular time of day, before I've taken this particular medication, this functional change in me might happen. And by now knowing that in advance, I can then put off that particular element from happening. So it's one of those things we want to take the next step for. Improvement in management and oral medications. We've touched on this. I think this is a lost art. Therapists need to recognize that getting to the medications, opening those meds, understanding what med is for what disease process, doesn't mean we're teaching about medications. I don't know all the new meds that are out there, but I can read the label. I understand from the chart what this med is for. And if the patient can make that connection with me, then I'm making that, we're moving that down the path. But having the patient be able to problem solve, go through, this medication is now empty. How are you going to get more? What if you didn't have all the medications you needed today? How are you going to get to it? What if you forgot to take this one medication? What would you do about that? All of those questions are really insightful and help you to understand what's the patient's ability to take these medications. And then you put those steps in place to improve upon them. Additionally, even if the patient can't improve for it, you can put things in place that will prevent a problem with it, right? Many times we hear about the lack of the patient's ability to take a medication routine regularly or have their medications taken regularly lead to hospitalization. So again, putting things in place to assist a patient that needs it goes all that much further. Diagnosis-specific assessment tools, I'm going to talk about that in another slide real briefly, what those mean. And then addressing the patient satisfaction survey elements. That was on that value-based purchasing slide that Cindy had. I think it's 30% of your value-based purchasing score comes from the patient's response to the survey. The patient holds 30% of your improvement in their perception of your interventions with them. So did you scratch their itch? Did you do what they wanted you to do? So making sure we know from the beginning, what is the patient's goal? What is the patient's target? What is their focus? And making sure you address that each time. And have the therapist understand, what are the questions on the survey? Go through them. Doesn't mean we teach to the survey, meaning you don't have to go through each individual one with the patient. But understanding their role in those survey elements goes a long way to make sure that 30% is not a problem for the agency. All right, so let's talk about what's durability of response. It's a long-lasting positive response. So to Cindy's really great weight control, right? I can go on a diet. I can learn all this stuff. I can go to a nutritionist. I can get a trainer on the scale, off the scale. Boom, I did it. Now I'm not going to go to the gym anymore. Get rid of that trainer and the nutritionist has hit the road. Am I going to maintain? Can I maintain the weight loss when I don't have those people around me holding me accountable anymore? Potentially. For me, history shows no, I cannot maintain the weight loss. But for our patients, we want to make sure, what is it about when they're with us and they're doing things with us, when we're gone, how do we make sure they still do those things? So we have to put things in place, environmental adaptations, teaching education to family members, modifying how a patient understands what they're doing with us, helps to lead to that sticky stuff. They have to be able to do what they're doing with us when we are not there. And the longer that can be maintained, that's a long durability response. The response endures over time. But if I have to be there to get a good response out of a patient, that is you have failed to some extent for working on that level of independence with the patient. The patient will never be able to achieve that without you being present. So then we turn that over to a family member. Can the family member get that response out of the patient? Maybe, maybe not. Is it too hard? We need to analyze those things. And the only way to, I believe, truly analyze that is you have to take a step back from care. You can't be treating the patient 3 times a week for 2 weeks, 3 times a week for 3 weeks, and then boom, I'm done. Back out. If I'm seeing change, and then I suddenly stop, I haven't tested to see if I give this patient a full week without PT arriving in the home, and I show up on that 8th day, did the patient keep doing, are they doing what I expected them to do when they were doing 8 days ago? So you have to take a step back, slowly titrate your visits slowly out of care. You may not be doing more visits with the patient, doesn't mean add more visits. It means run those visits out over a longer period of time to potentially prevent a rehospitalization. Can they hang on to the stuff that I want them to hang on to when I'm not there?
Shannon, I want to interject there because I think there's been a long mythology around the idea that therapy has to go every week or we're going to get denied. Or that, you know, if you go a lower frequency like that, doesn't it mean you've now done maintenance, as if the frequency itself defines it? Or we've also heard that, you know, therapy can't do PRN visits. I mean, PRN visits are a nursing thing. Can you speak to that? Because I think sometimes what feels very comfortable to you, I think at least 1 or 2 people fell over at the idea of, I can skip a week, because I've been told that a 0 week 1 is like the kiss of death on a state survey.
No, there's no, you can, as long as there's not an agency policy against it, which would be unusual, there's nothing in the regs that say a 0 week 1 visit by a therapist will lead to a sudden need to discharge the patient. There's nothing that says that. And especially if you outline that in your chart and you're in the visit prior to a 0 week 1, patient is going to be held for 1 week to determine the durability of response of care, to be reassessed upon 8 days from now. Therapists will be looking to see no falls, ability to continue to use assistive device appropriately. We'll interview caregiver as to the patient's nutritional intake during this time, right? Whatever your target is, that's fine. So yeah, 0 week 1 is absolutely appropriate. Same thing with the PRN. You can have a floating visit, just like a nurse can. I think it's great, especially when you have those medically complex patients or an orthopedic patient who you know is going to go to an orthopod or an orthopedist in the middle. So you have some of these visits, but you say, I want to wait until that weight-bearing status has changed, and then I might want to throw in another visit or another visit the following week. Those PRN visits can then be doled out appropriately. You might have to have a talk with the agency on how to do that. But if they start to push back, we want to make sure that we support them in the concept that this is not against regulations. We need to figure out how to do it in their EMR. Potentially, their EMR might be a limitation, but we don't want technology to limit our ability to appropriately treat the patients, and we'll have to find our way around that. But no, that's absolutely appropriate in home care. You can do a 0 week 1, 0 week 2, and then a 1 week 1 or a 1 week 2 to then get the patient back involved again. I think once you start explaining the why behind it to the agency, why I want to put this gap, the light bulb might go on for them.
Well, I think that's always the devil in the details, Shannon, because I've probably seen the other million notes that are out there. And it's like, okay, so you missed a visit and it didn't matter because they were doing just as fine without you. Or I see missed visit due to scheduling conflict or just missed visit for no reason. I think, you know, that's, if we're going to do what you just described, I want to reinforce that the intentionality behind I'm, you know, going to assess durability of response and reassess on this date speaks to skill more than it just looks like, oh, I went on vacation for a week and I wasn't available and they said no one could come. So I just skipped a week and I'll just pick it up where I left off.
Absolutely, absolutely. While I see the benefit of the needing to take a week off, that is not the point of the 0 week one, right? All right, so I think we're going to finish up with the last my last slide here. Diagnosis specific assessments. Are your therapists assessing what we think they're assessing, or are they thinking what they think they're assessing? You have a patient that comes in with a primary diagnosis of a respiratory impairment, pneumonia, let's say. Are they targeting some of their assessment to a respiratory assessment? Do they have vital signs related to the patient's breathing support? Are they looking at functional endurance with the vital signs? Or are they just doing the typical patient ambulated 50 feet with a rolling walker and min assist, and they have a lower extremity strength of 3 out of 5? Or even worse, 4 out of 5. Okay, strength's not their problem. What's causing this deficit? Why can they only walk 50 feet? The problem becomes you have a primary clinical diagnosis that's saying all this home care is coming to the patient because of a breathing problem. And if you have a full-on PT eval or a full-on OT eval that does not address one bit of a respiratory impairment, you place the agency at risk for a reviewer to question the respiratory component, the respiratory clinical group that's been chosen. So you want to make sure that the therapists recognize, okay, what's the primary reason? They should be involved in the discussion surrounding the primary code for home care. And if it is respiratory in nature or cardiac in nature, some of their elements of their standardized functional mobility assessment should include tests and measures that target that particular clinical grouping. So if it's a respiratory, or we do dyspnea scales, functional endurance with a vital sign analysis, vital signs before, during, and after activity, as well as a narrative that explains the analysis of those comparisons. Gait speed index, you want to know how functionally the patient is ambulating with that speed, because we know very, very slow gait is not functional for some of our patients, and respiratory-wise, that could be used to support that. So again, this goes also back to what Cindy was mentioning earlier. Why is the impairment present? The why. Why are we all bringing all of these services to bear to a patient in home care for a respiratory impairment when the therapist who is now treating primarily, nursing may not be in, why are we talking about respiratory and the therapist is not addressing it at all? So I think it's a gap. We need to make sure that we address that particular gap. So I think that brings me to the end of my elements.
Before we go there, Shannon, because you're sparking thoughts. This is what happens when I have co-presenter. I think sometimes you have to acknowledge that to a certain extent, we're probably preaching to the choir a little bit on some of this stuff. But what are your thoughts in terms of the value of a therapist who's doing what you described here versus one who refuses to touch the OASIS, still argues that vital signs don't need to be taken other than if you make me one time during the visit, and I don't even bother to say when. Whatever, I just use whatever tools are given to me by the EMR. And if it's not in there, I don't do that, because I see a lot of what, Dee Cornetti has christened the Tonetti tug train, that those appear to be the only tools that are being used by PT in particular because they're in the EMR. If we're talking value, what do you see, especially in your day job, as it were, the difference in value between those two clinicians?
Well, if you have an agency that recognizes that value, so to your point, we have agencies who the value they see in that PT you just described, who doesn't care about vitals, I'm not touching the OASIS, and I'm only going to do the tests that are in the EMR. Some agencies, to their detriment, see the value in that PT in that they go to all their counties. That, you know what I'm saying? So there, right. You have to have an agency who recognizes the value of a clinician, who protects them as a provider, and doubly actually has an impact on the patients that they treat. If I have an impairment, let's say I'm receiving services for something, and somebody comes into me and does an evaluation and never really addresses what my problem is, I'm going to see what you're doing with me is not going to have any impact. I'm going to draw the connection that you are not of value to me. And some of our home health customers don't see that. They see the value in the clinician as, hey, they go anywhere they want. Every time I call them, they say yes, and they drive to the ends of the earth. And I think that's a really low bar for the value of a clinician. The value in a clinician should lie in the ability to perform differential diagnosis, should be to identify the functional impairment or the functional deficits and the impairments that create that deficit, because that's the only way you're truly going to get an outcome for the patient, to prevent them from coming back under your service again 3 months later, to prevent them from being hospitalized 2 weeks after you discharge them, and to prevent them from being placed in a higher care situation, whether it be an ALF potentially, or a skilled nursing facility, because we didn't put in place, we didn't identify the things that should have been put in place to prevent that patient from transitioning into that particular higher care environment. So I'm going to put the onus on the value in both places. The clinician needs to recognize that their value lies in their ability to fully treat the patient based on an appropriate assessment based on the characteristics they see. And I'm going to place the value of that clinician to the agency. The agency also needs to see the value of a clinician who's willing to do OASIS, who's willing to do a thorough and accurate OASIS, as well as not just drive to all their 7 counties, but actually perform and provide care that's appropriate and document it to avoid risk for the appeals process. So that's my thought there.
So in the interest of time, what I want to call people's attention to is we have provided the speaker contact information for all 3 of us today, because we know sometimes you think of a question later, or as soon as you end the call, you go, wait a minute, I thought about something. So you have that for future reference. But Sherry, I want to tag you back in to see if you have any questions that have come in, any thoughts about what we've talked about today, so we can address anything that may have been submitted by an attendee.
We have not had any questions submitted as of yet, and I wanted to say thank you to both of you guys for giving such great information out. And just echoing what you said, Cindy, if you have any questions, please don't hesitate to reach out, and we will get back with you as soon as we possibly can.
Now, I understand at times there's been some confusion when we reference like Home Health Compare, and Shannon said it was important that you take a look at it. If you're not familiar with where that document is, it's a pretty quick Google search to go to the CMS website, and you're looking for Home Health Compare or Care Compare. It's available for home health agencies and for skilled nursing facilities and other elements of healthcare. It's not a home health exclusive thing, but it's a very interesting tool in that I want to echo what Shannon said. It's forward facing, it's community accessible. So it's meant to be, if someone needs to choose a home health provider in an area they're unfamiliar with who provides, you can put in zip code and find out who covers that area. You can identify an agency by name or narrow it down to a few names you might recognize and see what those performance scores are. So I always challenge therapists and nurses in home health agencies to take a look at those. If you haven't looked at them, it would be good to know what your agency scores are and what others might be. I've also seen therapists utilize that as a part of the preparing for an interview process, Shannon, to come in knowing what the performance or underperformance of a home health agency is, and come in prepared to speak directly to their ability based on a lot of what we talked about today to move the needle on some of those, not just in terms of I am the most wonderful therapist ever and I will fix all of this myself, but that mentorship, that changing the path. Because if they've gotten very used to, I have, a therapist who's alive and willing to go to 7 counties, meeting someone who can speak to those bigger issues and do it in a way that isn't condescending, but I've seen it be a very effective, even on being on the interviewer end of encountering individuals who have prepared in that way. So I think that information, a lot of the other stuff, when you get into some of the nuances of what's reported and the data and some of that, is more given to the agency and a little bit harder to get to sometimes as a frontline person, but you can get it from Home Health Compare.
Cindy, I just wanted to add a little caveat to that. If you're looking at that as a potential employer, you want to make sure you pay attention to some of the disconnects that we often see in the value-based environment, especially with the stars. If you only look at the 5-star agencies, you may see some disconnects that we find often when we're looking at them. For example, they may have a 2% rehospitalization rate, but yet they don't get anybody better walking. And so you want to make sure that information that you're reading is consistent and makes sense to you clinically.
And I would add to that, I very much prefer looking at the individual outcomes versus the stars, because the model was built intentionally that 50% of agencies are supposed to end up with 3 to 3.5 stars. So it's a bell curve issue. It's not the same as the star ratings for your favorite restaurant or movie. It's not strictly if I work harder, my stars will automatically go up. Sometimes everybody working harder just shifts the bell curve a little bit, and we stay where we are. So that's not meant to be a disheartening thing, but like Sherry said, it's finding the balance between, don't just look at the star ratings thinking it's like a movie. Make sure you look at what those outcomes are individually and what potentially could be done to help with that.
Thank you so much, Cindy and Shannon and Sherry. This was such great information, and we really do appreciate all of your expertise and your time today. And just as a reminder, today's session was recorded and it will be available on NARA's portal with the slides and all of the information. So thank you so much, everybody. Have a great day.